Hello, hello. This video is entitled The Bookwalter Retractor, Principles of Usage and Assembly. My name is Edward Shipper. I'm one of the Surgical Education Fellows at the Goodman Surgical Education Center at Stanford, and I made this video with the help of my co-fellow, Brittany Hasty, and with Ron Zhao, a staff trauma surgeon at Santa Clara Valley Medical Center. You can follow us on Twitter at gsec_surgery, and you can also follow Brittany at Brit N. Hasty. I don't have Twitter yet because I'm afraid of trolls. First, let's review some goals and objectives. The goal of this video is to understand how a Bookwalter retractor works and to prepare you with the knowledge and skills to set up the Bookwalter retractor in the OR. After viewing this video, the learner will be able to describe the purpose of the Bookwalter retractor, identify the components of a Bookwalter retractor set, explain strategic decisions when setting up the Bookwalter retractor, and assemble the Bookwalter retractor in the OR. As with all retractors, the purpose of the Bookwalter is exposure. If you can't see, you can't operate. The quote, "Good exposure is the key to good surgery," is often attributed to Dr. John Bookwalter, the inventor and namesake of this classic surgical retractor, but he actually got his quote from his mentor, Dr. Cornelius Sedgwick. The Bookwalter, or the Bookie as the kids are calling it these days, is a self-retaining retractor. The inspiration for the device came to Dr. Bookwalter during his residency training, when he was elbowed awake after falling asleep during a case where he had been relegated to holding a retractor. He later complained, quote, "This is ridiculous. I'm not learning anything. I can't see anything," end quote. Residency back then must have been a lot different. I never end up holding retractors in the OR. Unfortunately, Dr. Bookwalter's hands-freeing invention created a new problem for residents: being able to set up the device. To be able to assemble the Bookwalter, we first need to identify the components of a Bookwalter retractor set. The first component of the Bookwalter set is the post. The post has a groove at one end that is attached to a side rail on the operating room table so that the post extends superiorly towards the ceiling. It serves as the initial scaffolding from which the rest of the retractor set is built. The second component of the Bookwalter set is the arm, also described in surgical catalogs as the horizontal bar. The arm will eventually house the ring, and like the post, features a groove for this purpose. Unlike the post, the arm usually has a joint for adjusting the location of the ring, which helps distinguish it from the post. The horizontal bar can be connected at any point along the post, and as the name implies, it extends the scaffolding horizontally towards the surgical field. In order to connect the arm to the post, a coupling device is required. This appliance has two holes, one to receive the post and one to receive the arm. The coupling device is inserted onto the superior free aspect of the post and can be slid to the desired height along the post based on the height of the surgical field. The height of the coupling device sets the height of the arm. The arm is designed to receive the ring. Rings come in different sizes and shapes to accommodate different surgical fields, but every ring serves as the final piece of scaffolding on which the various retractor blades can be housed. Each Bookwalter set comes with a variety of retractor blades of varying shapes and sizes to perform different functions. Here, we'll review some of the commonly used blades in general surgery. The Balfour blade, or bladder blade as it is commonly referred to, has a shallow depth profile. It is called the bladder blade because it is often used at the inferior aspect of a midline laparotomy incision to retract the body wall near the bladder. Note that the shallow profile allows retraction of the body wall without retracting and thus traumatizing the bladder. The Kelly blade has a greater depth profile and is often used to retract the body wall. It is a versatile blade that can be used in a variety of locations. The Harrington blade, also known as the Sweetheart for its heart-shaped distal profile, is used on more friable tissue such as the liver or spleen. Note that unlike the Balfour or Kelly blades, the Harrington blade does not have a distal lip that toes in. This helps prevent any iatrogenic trauma to the tissue being retracted. A malleable can be shaped by the surgeon as needed to optimally retract tissue in the surgical field. These are just some of the commonly used blades in general surgery. You may encounter others not mentioned here within the various subspecialty cases. Blades are connected to the ring using a ratchet device. You may have noticed that the handles of each blade have grooves along a single face. This means that the handles of the blades must be loaded into the ratchet in the proper orientation to engage the ratchet action that allows for self-retraction. More on this later. Each ratchet allows you to make several adjustments to your retractor blade. One of the adjustments is the amount of retraction. This is determined by how far you load the blade using the ratchet action. Another adjustment you can make is the amount of angulation of the blade into the field, commonly referred to as the toe-in function. Each of the levers on the ratchet device releases the ratchet action and allows you to reposition the blade as needed. To recap, the post is connected to the OR table, the arm is connected to the post using a coupling device, the ring is connected to the arm, and the retractor blades are connected to the ring using ratchets. Now that we have reviewed the components of the Bookwalter retractor tray, we will review some practical tips so that you can assemble it in the OR. Placement of the post first requires some strategic decision making. The post should be placed on the same side of the table as the primary surgeon to facilitate intraoperative adjustments during the case. Furthermore, depending on the location of the operative field, the surgeon may choose to place the post at the head of the bed for cases involving anatomy of the upper abdomen, or at the foot of the bed for cases involving anatomy of the pelvis. Once you have decided on the location of the post, you can place it. As mentioned previously, the post has a groove at one end that engages with the side rail on the operating room table. The post is then locked onto the side rail using the tightening screw action of the handle. Note that in the operating room, the post will be placed after the patient has been prepped and draped and you are sterilely gowned and gloved. Thus, placement of the post will occur over the drape. Different posts have different handles, but each work using the same principle. Make sure to pad the pole as needed to offset any contact pressure on the patient. In order to attach the arm to the post, the coupling device should be slid onto the post first. Different coupling devices have different orientations and locking mechanisms, but the key point is that the coupling device should be engaged with the post such that the arm will be positioned away from the surgical field. This will create more working room for the surgeon. Once the coupling device has been attached to the post, the arm can be connected to the post. Again, the arm should be positioned away from the surgical field. Note that the arm also has a groove that will receive the ring, and the arm should be positioned in such a way that this groove projects towards the surgical field. Note that the height of the arm can be adjusted by sliding the coupling device along the length of the post. You should adjust the height so that the ring and associated retractor blades are a few centimeters above the body wall. As we will see, adding these few centimeters of working room will help prevent iatrogenic trauma to the body wall by the retractor blades that will be attached to the ring. Once the arm is connected to the post, the ring can now be connected to the arm. Again, you have some strategic decisions to make. First, you need to select the correct size and shape of the ring. In general, this decision should be made to match the size of the incision and the operative needs. Additionally, you need to decide where to center the ring. A common mistake is to center the ring over the incision. You can help yourself by positioning the ring over the organ of interest. This will allow you to maximize retraction forces and bring the surgical field from the incision to the organ of interest. For instance, in a trauma exlaparotomy for a ruptured spleen, the Bookwalter ring should be centered over the spleen and not over the midline laparotomy incision. Once you have decided which ring you want to use and where you want to center it, you are ready to lock the ring into place. Note that many arms have two locking mechanisms. One mechanism will lock the ring into place on the arm. Another mechanism also adds an elbow function to the arm, allowing for fine adjustments to the location of the ring. You should lock the ring into place first before making these fine adjustments for ease of use. Once you have positioned the ring, now you are ready to attach the retractor blades to the ring using the ratchet devices. Once again, you have some strategic decisions to make regarding the location of blade placement. In general, the Bookwalter device generates its retraction forces by pairing blades opposite one another along the ring in a balanced fashion. A standard initial setup of the Bookwalter involves placement of 4 body wall retractors along the circumference of the ring. Additional retractors can then be placed as needed to retract the intra-abdominal anatomy for surgical exposure. Once you have decided on the location of blade placement, you can load the blades into the ratchets. The blades should be loaded in such a way as to engage the ratcheted edge of the handle. To do this, orient the handle so that the ratcheted edge faces the lever. If you have loaded the blade correctly, you will hear a characteristic clicking sound. Now you can place the assembled apparatus onto the ring. Each ratchet has a slot that engages with the ring. Notice that there is no locking mechanism that connects the ratchet to the ring. The ability of the ratchet to stay in place relies on tension generated by the retraction of tissue. For ease of use, you should load your 4 foundation retraction blades loosely into the surgical field before cranking back for full retraction. You may want to place a laparotomy pad between the blade and the retracted tissue to minimize trauma. Also, remember that we recommend positioning of the ring a few centimeters above the body wall. This creates working room to allow the toe-in function of each ratchet without inflicting trauma on the body wall. And that concludes our video on the Bookwalter. Good luck in the OR.